Doug comes to us from having worked with Sharon, so I know his work long before. And then I was actually talking with Sharon about another grant, and she's like, do you realize that Doug Leslie is now at Penn State because you came here from Yale? So I'm like, oh my gosh, I'm going to call him up immediately. And he was nice enough to answer the phone. And so now I actually get to work with Doug. And Ed Marcantonio and I are MPIs on a really cool grant called READY, Researching Efficient Approaches to Delirium Identification. And Doug is doing the cost analysis and looking at 3 different types of screeners. A nursing assistant, we have screening delirium, a registered nurse, and physician hospitalist. So we're very excited to have him working with us. Doug is a health economist, professor of public health sciences and psychiatry at the Penn State College of Medicine, which is, by the way, 2 hours away. A lot of people think it's here on campus. It's not. He's also director of the Penn State Center for Applied Studies in Health Economics. He has over 120 peer-reviewed publications spanning multiple areas, not just delirium. Actually, I think you said the other day most of yours aren't in delirium, but cost and cost-effectiveness analysis, pharmacoeconomics. He has extensive experience with delirium, and again, has written really the seminal paper on the societal impact of the cost of delirium. So we welcome you.
Great. Well, thank you very much. Thanks. So one thing that I'm kind of proud of that Donna didn't mention, if you take Center for Applied Studies in Health Economics and take the first letter, it spells out cash. Very, very proud of that one. We worked hard to think up that one. Okay, so thank you very much for that very kind introduction. I'm very happy to be here. So today I'm going to talk about the health economics of delirium. So just kind of a brief outline of what we're going to do today. What is health economics and why do we care? We'll talk a little bit about the economic burden of delirium, which I didn't know this, but you guys have all read my paper, so it's going to be a review. And then computing, how do you compute the costs of delirium interventions, which is what I'm helping with the READY study that Donna mentioned. And then kind of taking it the next step, how do you conduct cost, benefit, and cost effectiveness analyses, and what use are they to folks, like you? So what is health economics? Health economics is a sub kind of field within economics. Economics is all about studying how people react when faced with scarcity. So people's wants are infinite, but our resources are finite. So how do we then make decisions? How do firms behave? How do consumers behave? What role does government and policy play in all of this? So that's kind of economics broadly. Health economics is just applying those concepts to health. So looking at a definition given by the Johns Hopkins Bloomberg School of Public Health, health economics is an applied field of study that allows for the systematic and rigorous examination of the problems faced in promoting health for all. By applying economic theories of consumer, producer, and social choice, health economics aims to understand the behavior of individuals, healthcare providers, public and private organizations, and governments in decision making. So that's an incredibly broad definition. There's a lot going on there, right? I think a lot of times people think of health economists as only dealing with costs and cost effectiveness, but as Donna mentioned, most of my work is actually looking at how kind of broad policies affect access to care, quality, and costs. So it's a very broad field. So what can economics do for us? Well, there's several classes there's several things or issues that economics can kind of talk about or help us understand. So how to allocate healthcare resources. So what are the optimal staffing ratios on an inpatient ward? Or where should we be setting up outpatient clinics to keep patients more engaged in care? Those kinds of issues. How do we allocate our healthcare resources? How do consumers in the case of health, it's their patients, how do patients behave? So what affects engagement in care, following up with prescribed treatments, all that kind of stuff, and how do we improve our healthcare system to encourage patient engagement in care? How do healthcare providers behave? So how do we get people to screen for delirium? How do we create incentives for clinicians to provide the care that we think is evidence-based, right? So that we can improve care for all while limiting the resources that are being spent. How do we design efficient healthcare systems? So what's the best way to organize and finance our care? In the United States, we've chosen a very unique way. of organizing and financing our care. And if you compare it to how things are done in other countries, we don't do so well. So what can we learn from other countries and how they've chosen to organize and finance their healthcare system to help improve our system here? And then what role should government play in healthcare delivery? So are there, again, policies that can encourage the efficient use of resources to try and get, the right care to the right patient at the right time for the lowest cost? So there's a lot that economics can do for us. How does economics do this? Well, there's lots of different classes of economic evaluations. So these are different types of studies that all would fall kind of under the umbrella of health economics. So there's cost analysis, which is, you've developed a new intervention to treat some condition. How much does it cost, right? So you've thought long and hard about what kind of ingredients go into this new intervention, but understanding the cost side of that is also very important. So that's what cost analysis does. And we'll talk about all of these in more detail in a few minutes. The second class is the cost or burden of illness study, and that's the study that Donna referenced. And the idea of that is to kind of bring attention to a clinical issue. And so we'll talk about that in a few minutes as well. Then there's cost-benefit analysis, which looks at, are the monetary benefits from an intervention bigger or less than the costs of doing it? And then there's cost-effectiveness and cost-utility analysis, which is all about comparing the cost of an intervention to the clinical benefits that it derives. So again, we'll talk about those in a few minutes as well. Okay, so burden of delirium. So you guys all know this, but it turns out that delirium is not the kind of no big deal transient condition that people traditionally thought it was, right? People used to think that delirium was something that some patients got, no big deal, a little confused, it'll resolve, we don't need to worry about it too much. But it turns out that patients who have delirium actually have higher health care or higher hospital and nursing home costs. The magnitude of that difference depends on the clinical population. So in a post-operative situation, they may be different than in an ICU, but they're higher. And it's not just those costs. It turns out that after they're discharged, their costs over the next year are also a lot higher. And again, these can be significant. So when you add it all up, so a study that I published several years ago with Sharon, we estimated that delirium is responsible for $143 billion to $152 billion each year in the United States. So you look at a number like that and you think, wow, that's a lot. It's clear that delirium is more kind of significant than maybe we thought it was. But it's hard to kind of understand those numbers without some sort of context, right? So if we take these numbers and compare them to other conditions, so we compare it to similar studies in other conditions. So there's delirium here at the bottom, the 143 billion. I took the lower end of the range to be conservative. And if we compare that to hip fracture, 7 billion, non-fatal flaws, 19 billion, diabetes, 91.8 billion, and cardiovascular disease is more expensive at 257 billion. But you can see that delirium is a much bigger deal than lots of other conditions that already receive significant clinical attention, right? So why aren't we paying more attention to delirium? So my hope is that studies like this will start to kind of trigger or foster those kinds of questions. Okay, so the nice thing about doing studies like this is that there's more research into interventions to prevent or treat delirium, right? So suppose you've developed an intervention and you've shown that it works. What's next? You want to disseminate it, right? If you have an intervention, you've shown that it works, the next step is to go to insurance providers or healthcare system administrators and say, we want to disseminate this intervention more broadly. So what's the first question they're going to ask you? How much does it cost, right? So figuring out the cost of an intervention can be a challenging thing to do, right? Sometimes it's kind of easy. If you just need to hire another clinical staff person, you can take that person's salary and say, that's how much the intervention costs. But often, especially with these multi-component interventions, there's lots of different ingredients that go into them, right? So that's where you need a cost study. So that's to determine how much the intervention actually costs. So one way to do that is with a technique called microcosting. So the way microcosting works, there's several steps to it. So step one is to identify all of the inputs. So what are all of the things that go into your intervention? So what kinds of clinical staff are needed? What kinds of administrative staff are needed? What other kind of materials or supplies or equipment do you need for your intervention? So you just kind of make a list. What are all the things that you need? And then the next step is to measure how much of each of these inputs is being used. And again, sometimes that's easy. If you need 50% of a registered nurse, then that's pretty easy to figure out. But sometimes it's actually quite complicated, and it can get down to following people around on the clinical floor with a stopwatch and saying, okay, they spent 2.5 minutes doing this activity for the intervention, and then they moved on and did something else. So that can get quite time intensive to figure that out. And then step 3 is to come up with unit costs. So how much does each unit of these various inputs cost? And again, sometimes that can be easy. So if it's clinical staff, you can go to HR and ask, how much do we pay for a registered nurse? And then kind of break that down, take their annual wage, break it down to an hourly wage, or even a wage per minute if you need to. And then for other kind of equipment and supplies, those can be pretty easy too. And then step 4, you multiply what you found in step 2 with the unit costs in step 3, right? So that'll tell you then how much you're costing or how much you're spending on each of these inputs. And then finally, you sum across all the inputs, and then you have the cost of your intervention, okay? So after you do all this, you have a number, but you might think, well, there might be some variation around that cost, right? So often we'll do sensitivity analyses. So we'll say, all right, so in terms of how much of each input was used, maybe the time that was spent by the registered nurse, varied quite a bit, right? From some patients, they were really quick. Other patients, they took a long time. So you look at that distribution, and for the first kind of estimate, you just take the average, right? But then for your sensitivity analysis, you might vary that within the distribution at like the 25th and 75th percentile or something like that. And you do that across all of your inputs so you can see how much your estimate of the cost might vary depending on these things. And then the other thing that I like to do is so you might have the intervention kind of, what does it cost as designed, right? So in our original design, maybe we have a registered nurse who's doing, these assessments on patients, but is that something that a CNA could do, right? So you might kind of recalculate your cost based on the cheapest unit that might be able to perform that function. So again, you'd have kind of the cost as delivered, but then you'd also have this kind of best case scenario that it could be as cheap as this, right? Okay. So after you do your microcosting and you have your cost of your intervention, the next step is to look for potential cost offsets. So does this intervention save on future healthcare costs? And that's what a cost-benefit analysis is all about, okay? So in cost-benefit, this is something that you do before implementing a new treatment, and it asks the question, should this new treatment program be adopted at our clinical center, okay? And so you measure both the costs and the benefits in monetary terms. So it's got a very narrow focus, right? It's only looking at cost savings relative to the costs of the intervention itself. And then if the cost savings are bigger than the cost of the intervention, then the decision rule is easy, right? You say, yes, we adopt it. But if it's not, then it takes more work, and we'll get to that in a second. So does your intervention lead to cost savings in other areas? And if it does, then you can implement your new treatment program. So estimating these cost savings can sometimes be difficult, right? So if you have an intervention that costs some amount of money but reduces length of stay or reduces rates of readmission, how do you figure out what the cost of that is? So there's lots of different ways to do that. One way is to look at published literature. So have other studies used an estimate of the cost of a hospital day for patients who kind of look like your patients, or the cost of reducing a length of stay by a day. So if there's estimates in the literature that are fairly recent, then you can use those. If there aren't, what you could do is go to a claims database. So there are databases out there like Medicare claims or private health insurance claims that will have the amount of money that the insurance pays to the provider for that particular service. Okay? What you don't want to do is use hospital charges. Okay? A lot of folks say, oh, I'll just go to my hospital leadership and ask, what do we charge for an inpatient admission? The problem is nobody pays those prices, right? The only people who pay those prices are people who don't have insurance, because insurance providers negotiate with healthcare providers, right? So the charge list has really no relationship to costs at all. So don't do that. If that's the only resource that you have, there are some tricks for trying to convert a charge into a cost using some data from CMS, but that's fraught with peril. So I would encourage you to first look in the literature and then see if you could find somebody with access to a claims database to help out with that. Okay, so suppose now you've done your cost-benefit analysis, and unfortunately, the cost savings don't offset all of the costs of the intervention. So your intervention is more costly than treatment as usual. What do you do next? So next, you have to do some sort of evaluation. Are the benefits that are derived from our intervention worth the extra costs that we've incurred? And so that's the value in healthcare question. So determining the value asks, are the benefits derived from implementing the intervention worth the costs that must be incurred? And we can think of it as a trade-off, right, between cost and quality. So we can kind of, I shouldn't put an equal sign there, I should put like a squiggly equal, because it's not actually a mathematical equation, it's more of a concept. You can think of value as being quality divided by cost. So the higher the quality, the higher the value, and the lower the cost, the higher the value, right? If you have a smaller number in the denominator, then the result is going to be a bigger number. So that's what economic evaluation attempts to do, is to combine these concepts of quality or effectiveness and cost into a single measure that we can use to try and make decisions about whether to implement a program. And we do that one way of doing that is with cost effectiveness analysis. So in cost effectiveness analysis, we're comparing two or more interventions. So one is usually this new treatment program that you've developed and want to test, and then the other is almost always treatment as usual or standard of care. So that's kind of the straw man that you're trying to knock down. And in this analysis, you'll measure costs, obviously in monetary units. It's hard to think of any other unit to measure costs. But outcomes are measured in whatever units are natural for the disease process that you're studying, right? So it could be patient survival, the years of life saved, or maybe in a delirium intervention, it might be delirium cases avoided, something like that. But they could be anything. And I've seen cost effectiveness analyses for, say, depression, and the outcome will be depression-free days, something like that, okay? And then you'll compute what's called the incremental cost effectiveness ratio, or ICER. So here comes more math. So this actually should be a standard equal sign. So our ICER is defined as the difference in costs. So if our new intervention is intervention 2, and the old treatment as usual intervention is treatment 1, then we'll take C2 minus C1, so the difference in costs, and then we'll divide it by the difference in effectiveness, E2 minus E1. And that'll give us one number that'll tell us what's the cost per unit increase in our effectiveness measure. Okay? So let's look at an example. And so I just totally made these numbers up, all right? So if they seem kind of weird, let me know so I can fix it. So suppose you have a new intervention for delirium that costs $12,000 and is associated with a delirium incidence rate of 3%. And suppose that treatment as usual costs $9,500 but is associated with a delirium incidence rate of 20%. And the question is, should we invest in this new treatment? So it's more expensive, but it's more effective. So let's plug this into our ICER equation and see what we get. So if we take our difference in costs, that's the $12,000 for the new treatment minus the $9,500 for treatment as usual, that's a difference of $2,500. And then we look at the difference in effectiveness. So if there's a 3% delirium incidence rate, that means there's a 97% non-delirium rate, right? So 97% of our patients don't get delirium. And I switched it like that because we want it to be an effectiveness measure. It should be a good thing, right? So if we had taken 3 versus 20, we'd be looking at cases of delirium that occurred. And instead, we want to look at delirium cases avoided. So we do the 97%, subtract 80%, we get 17% in the denominator. And you do the math and you get, it's $14,706 per case of delirium avoided. So is that worth it? Are we willing to spend $14,000 to avoid a case of delirium? It's hard to say, right? We don't really know how to interpret that result. So it's helpful then to plot this in what's called the cost effectiveness plane. Okay? So in this plane, we've got the difference in effectiveness along the horizontal axis, right? So things that are over here, the new intervention is more effective than treatment as usual, right? It's got a positive difference in effectiveness. And then along the vertical axis is the difference in cost. So things up here, the new intervention is more costly than treatment as usual, right? It's a positive difference in costs. So that then divides the plane into these 4 quadrants, 1, 2, 3, and 4. So suppose we have an intervention that has a ICER ratio that falls in quadrant 2, okay? So it falls somewhere down here. What does that mean? That means we have an intervention that is more effective, right? And it's less costly. So what's the decision rule for that? We like it, right? That's good. So we have a smiley face down there, okay? Those are good things. On the other hand, suppose we have an intervention that's up here in quadrant 4. That's an intervention that's less effective and more costly, right? So, right, big thumbs down on that one. So we don't like that at all. So things that fall in equation 2, or in quadrant 2 or in quadrant 4, really aren't all that interesting from a health economics perspective, right? Because the decision rule is easy. So down here in quadrant 2, we say that the new intervention dominates treatment as usual, okay? It's a dominant strategy. And up here in quadrant 4, we say the new intervention is dominated by treatment as usual, okay? So really all the interesting stuff happens in quadrants 1 and quadrant 3. But what's going on here with quadrant 3? In quadrant 3, we've got an intervention, a new intervention, that saves us money, but it's less effective. We're never interested in things that are less effective, right? Nobody's developing interventions that actually don't improve effectiveness. In fact, that's usually the first thing you test is my intervention effective? And then you look at costs after, right? If it's not more effective, we usually just kind of drop it. So there's almost nothing that ever happens in quadrant 3. So really all the interesting stuff happens up here in quadrant 1. So that's where you've got an intervention that's more effective, but also more costly. So we have to figure out how to deal with that. Yeah.
I guess I would just say some hospital administrators may focus on reducing costs, and if it reduces effectiveness by a small enough increment, they might be willing to accept that.
That is true. That is true. Hospital administrators may have a different objective function than others. Yeah. They may live a little in quadrant 3, yeah. All right, so suppose we have an intervention then that falls up there in quadrant 1, and it's this dot up here. So there's an intervention that's just a little bit more effective, but it's a lot more costly. So what do we think? Do we like that? Yeah, we got a thumbs down on the back. I think probably not, right? On the other hand, suppose we had a point down there where you have an intervention that's a lot more effective and just a little more costly. And there we say, yes, we like that, right? So up here we say probably don't do that one. And down here we say probably we would do that one. And then you can imagine as we start to move towards the center, we reach a tipping point, right? A point where, maybe we were willing to do it before, but if we move over this point, now we're not willing to do that. That's called the cost effectiveness threshold, okay? Or it's also sometimes called your willingness to pay threshold. And this is something that, health economists don't decide this number, right? This is a number that's determined from kind of a policy level, right? So in the United States, we actually don't do very much of this, right? There is no kind of explicit requirement to do cost effectiveness, nor is there an explicit threshold kind of below which we'll deem it to be cost effective and therefore widely available everywhere. But in other countries, they do. So in the United Kingdom, they have this National Institute for Clinical Excellence that requires that cost effectiveness studies be done. And they actually do have an explicit threshold. So if things fall below that, then that becomes a covered service under the national health system. Yeah.
When you do this, do you have error bars in there? So if it's a novel intervention and you're not exactly sure of what the cost is going to be, or you think you know what the effectiveness is, but you don't know on a large scale?
Absolutely. Yep. And what's tricky about doing that in this context is that when you have an error bar that actually goes from one quadrant to another quadrant, that's a problem, right? If we do our error bar and everything is up here in quadrant 1, or even better, everything is down in this section, then we say, great, not only is it cost effective, but the error all falls within our cost effectiveness, yes category. But if it kind of dips into other quadrants, then it jumps from being, cost effective to being dominated by the other thing, right? So it does get tricky, and there's actually ways in health economic evaluation to deal with that. We use a slightly different tool to do that, but yes, we do. And we'll see actually one in a few minutes. I've got a picture of one. Yes?
How do these models work in scaling? Because I can imagine that some interventions are very expensive to do when you do them in small numbers, but kind of like Costco or Sam's Club gets
Yeah, so that's a very good point. So and typically where you get the scaling is the number of patients who can be kind of serviced under the new program, right, or treated. So when we do a cost analysis for an initial intervention, there's usually a sample over which the intervention is being delivered, and that can be part of the sensitivity analysis too. It's like, how many patients do you think we could serve? So in the trial we served 500 patients. But how many do you think could be served by this new team that we've put together? And so that becomes part of the sensitivity analysis. Okay, so anything below that line, we say it's cost effective. But there are some limitations to cost effectiveness analysis, right? So only interventions that have the same effectiveness measure can be compared, right? So if you have 2 interventions for delirium, and your outcome is delirium cases avoided, then cost effectiveness analysis is fine. But suppose suppose you're a hospital administrator and you're trying to decide, should I invest in this new treatment for delirium, or should I invest in this new treatment for hypertension? Those are very different outcomes. And so what you do then is you use cost utility analysis. So cost utility analysis is actually just like cost effectiveness analysis. But the outcome is always the same. It's the quality adjusted life year. Have you guys heard of QALYs before? Okay, so quality adjusted life year, that's the only outcome. Everything's converted into QALYs. So we would take our cases of delirium avoided and convert it into a quality adjusted life year. So what's a QALY? So the idea is that 1 year of life in perfect health is not the same as a 1 year of life with some disability or morbidity, right? So what QALYs do is they adjust the survival time according to the quality of life during those years of life. So mathematically, it's actually pretty simple. You just take the life expectancy in years and you multiply by this utility weight. So the utility weight is really an important metric. So let's talk about that a little bit. So utility is a measure of patient preference for health states. So what they do is they get a group of people together, just from people who don't have the condition, and they tell them a story. They say, suppose you had this condition, and they describe what it would be like. And then they ask, okay, suppose you could take this magic pill and it has it has a 75% chance of curing you completely and a 25% chance of instantaneous death. Do you take the pill, right? And people kind of see, oh, yeah, I would take the pill, oh, I wouldn't take the pill. And then you change those probabilities, right? And you see where people kind of break even, and that's how they develop the utility weight. At least that's one method. There are actually a couple of different methods that people use to do these things. But that's the idea. You get a group of people together and you ask them, what would you do if you had this condition? So these utility weights, there's a range. It goes from 1 is perfect health, 0 is death. Of course, larger numbers are better. And this is a whole kind of field within health economics, developing these utility weights. That's been around for, probably since the 50s and 60s. So it's a relatively new field in health economics. So here are some reference utilities from one of the first studies. So this is a study done, it was published back in 1982. And it shows, it's a very simple utility measurement tool, and I apologize that the screen's kind of small. But you've got disability in this first column. It ranges from no disability down to confined to bed and unconscious. And then you've got levels of distress across the columns, so none, mild, moderate, and severe. So in this model, perfect health is defined as having no distress and no disability. And then as you kind of move across the distress columns, your weight goes down, and as you move down the disability column, your weight goes down as well. So if you get down to, say, confined to a wheelchair and unable to move around, and you're in mild distress, then your utility weight is 0.845. Okay? So this just gives you a sense for how these weights work. This is a very simple tool for trying to measure utility. There are much more sophisticated tools that people have developed. So there's something called the Euroqual. I don't know if you've heard of that, or the EQ5D, or Quality of Wellbeing Scale. There's lots of these kinds of questionnaires, and some of them you have to pay to use, but you can kind of then apply them in whatever population you have. Yeah.
Have there been studies eliciting utilities from people hypothetically versus people who actually have the condition, and are they comparable or different? Is it more
In terms of who
appropriate
yeah, in terms of,
like get people who are confined to a
Right.
wheelchair versus say you were confined to a wheelchair?
so the reason they want to do people who don't have the condition is because it's supposed to be a societal decision about what the utility weight is for this thing. Often when you ask people who have the condition, they rate their utility higher than people who don't have the condition, right? Because if you've been confined to a wheelchair and unable to move around for your whole life, then you've developed workarounds for that, right? And so usually you'll rate your quality of life higher than someone like me who's never been in a wheelchair. I'd be like, yeah, how am I supposed to get out the door, right? So they like to use a non-afflicted population to develop these utilities. Yeah. Okay. Yeah. All right. So there are some advantages to cost utility analysis. So the nice part is that this common outcome, these qualities, allow you to compare investments across very different areas, right? So you can, again, make that decision about whether to invest in a delirium intervention or invest in an intervention for some other condition, right? So back to our kind of story of how do we convince hospital administrators and policymakers to adopt our new delirium intervention. If we did a cost utility analysis, we could say, look, the cost per quality for our intervention is actually bigger than things you're already investing in. So therefore, shouldn't you invest in this as well? The other advantage is that there is an accepted willingness to pay threshold for qualities. Again, we don't use qualities here in the US very much as part of our policy kind of exercises, but they do in other countries. So in the United Kingdom, the policy threshold, I think, is £30,000 per quality adjusted life year. So if your intervention costs less than £30,000, which is a little less than $40,000, for a quality adjusted life year, then they deem it cost effective. So how'd they come up with that? I don't know. Yeah.
How do the qualities work in really heterogeneous societies where you might
Yeah, that's a great question. So, and the short answer is I don't know, because this is a whole separate field of health economics. There are people that specialize in this utility measurement stuff, and that hasn't been my specialty. But I do know that they worry a lot about that, and there are certain conditions, and I would think delirium would be one, where it can be very challenging to estimate a utility weight, right? So another area that I do a lot of work in is autism. And that's another area where we don't have good utility weights because it's hard to get a group of people together and describe what it's like to be autistic, right? So it's challenging. And yeah, differences in cultures and values, and some people may put a higher weight on not being able to interact with family than others, right? Depending on your culture. So my guess is that they try and take as representative a group as possible, and so all of these kind of average out, but I don't know for sure. Okay, so I could only find one example in the literature where people have done a cost-utility analysis around delirium, and it was a study that was done in the UK. So they used data that was part of the National Institute of Clinical Excellence kind of package, and so this is what they found. So here's the cost-effectiveness plane that we had earlier. So difference in cost is here, difference in effectiveness here. So remember, this is our quadrant 1 where all of the interesting stuff happens. And here's the threshold. Actually, they used a threshold of 20,000 pounds per quality. And so why are there so many points here? So this is trying to get a sense of the variation in the estimate. So what they did in this study, they didn't use a clinical trial or anything to do this. It's a modeling exercise. So they took estimates from the literature for, what are the things that can happen when people have delirium, right? So they're at increased risk of falls, increased risk of extended hospital stay, et cetera, et cetera. And then for each of those possible outcomes, they took estimates from the literature to say, a hypothetical patient with delirium has an X% chance of this thing happening, Y% chance of that thing happening, et cetera, et cetera. And then for each of the outcomes, they had a utility weight, again, derived from the literature, and a cost from the literature. And then they took a hypothetical cohort of patients and put them through this model. And so you do that once for patients with delirium, and then do it again for patients without delirium, and now you have your quality, right, or your cost effectiveness ratio, right? And then if you do that 5,000 times, you generate this cloud, right, which shows you, the variation around your estimate. So looking at this, we see that most of the cloud is down here in quadrant 2. So we would say that the delirium intervention actually dominates treatment as usual, right? But there are some up here in the quadrant 1, but still cost effective. And then there's some that are over here where it would be dominated. So if we took and they didn't do this, but typically you'll find an ellipse around this that shows you the 95% confidence interval around those estimates. So it looks like the 95% confidence interval would be contained in that quadrant 2. So just to kind of sum up here, there are some disadvantages to CUA. As I mentioned earlier, qualities have not been embraced in the United States, and there are some difficulties in estimating these utilities. So most of the work that's been going on in delirium has actually been cost-benefit, right? Trying to look for cost offsets from having better identification and treatment of delirium. But there's still, I think, a lot of work that could be done in this area to extend these things to cost effectiveness and cost utility analysis. So let me stop there and see if you guys have questions. Yeah.
In that last study you presented, how much credit, what happens in your mind about that study? I know that modeling is interesting and everything, but do you put a lot of credence in a totally hypothetical model in that particular instance where they're estimating the percentage of falls and other complications and then the amount of cost? That seems to get further and further away from what might not be real.
Yeah. So me personally, I'm not a big fan of modeling studies because you're taking estimates from the literature that could be based on very different clinical populations. And we already know from the literature that rates of delirium and delirium complications vary quite a bit depending on what population you're studying. So I'm not a huge fan of them. I've actually, I think, only ever done one of these kinds of studies. But there are other people who swear by them. So I don't want to be too dismissive. Yeah.
So I think his name is Victor Tabush. Do you know that?
No, it doesn't ring a bell.
So he's helping out the age-friendly health system. It's a big initiative where they have 4 areas: mobility, medication, meditation, and whatnot, or continuing for the quality. But one of the things he's done for health systems, and I guess it would be sort of modeling, but it's using local data. So that could be done too, right? Would you recommend? So
Oh, absolutely.
Trying to make a business case, and he actually provided a spreadsheet where health systems can plug in their local data. And I have to say that for delirium, it was stunning. Some of the, I think it was UCSF did this, Stephanie Rogers, who was at this boot camp, has done some of that work that she publishes. But, it's over $6 million, and then it was $20 million. Now, I think a lot of that was probably, you talked about, revenue enhancement versus cost savings, cost avoidance that you have.
Yeah.
A lot of different delirium and pursue as part of cost avoidance.
Well, and that tends to be the easiest pitch, right? If you can show insurers and healthcare administrators that your intervention actually saves money for those patients in some defined period of time, it's a lot easier to convince them to adopt the intervention, right? If you have to go to a cost effectiveness or cost utility analysis, now it becomes more of like a health policy issue, right? You're trying to convince, health policymakers to require health insurers to offer this intervention because the benefits, in terms of kind of functioning and quality of life are exceed the cost of the intervention itself. That's a tougher pitch because you're arguing to a different group of people. Yeah.
So you can meet tomorrow.
Yes.
Yeah, one question was saved.
Okay. I won't be able to sleep now.
Can you tell me again? I'll do it now. Can you tell me again in 30 seconds the difference between cost benefit and cost effectiveness?
So cost benefit is when you're comparing, everything is measured in costs. So the costs and the benefits are measured in costs. So you could do cost effectiveness in a cost benefit framework in terms of, valuing the outcome in monetary terms, but that's very difficult to do, right? How do you put a value on life, right? So maybe delirium case avoided, maybe we do have good estimates for what the monetary value of that is, but really it's only in terms of saved service use, right? It doesn't include things like, caregiver burden or kind of reduced quality of life, because you've had this episode, right?
Okay, so here's the other question I was going to save for tomorrow. Earlier today we were talking about pilot studies and looking for target effect sizes for interventions. Have you ever been approached by or seen anybody wanting to know what's the minimum effectiveness I'm going to have for an intervention in order to get into one of these quadrants or fall under the cost effectiveness ratios, the ceiling?
So not exactly, because it's always relative to the cost, right? So there is no kind of,
Right. Well, if you know the cost of the intervention ahead of time, you would be able to know how effective would my intervention have to be in order to fall into the right spot on that
right,
quadrant.
yeah, I think, yeah. I mean, I've never been approached for that, but it sounds reasonable.
Okay, good, we will be
Uh-oh. Let me rephrase my answer.
Okay, so join me, and I just realized that our gift is something that will help prevent delirium,
Oh, fantastic.
hydration.
Yeah, great.
So join me in thanking Doug.
Thank you very much.